All right, everybody have a good break. Sometimes you need a little break just to move around, but I went over all that initial stuff, which is a lot of the esoteric didactic information, which you have to have, because they can't have you go out and do injectables if you don't have some of the basic knowledge. But now we're going to get into the stuff that's the nuts and bolts and the nitty gritty of it, so you'll really understand where that needle's got to go and how it's going to go in and all the rest of it. So this particular talk, I'm going to describe the muscles of the face, mainly the facial expression muscles, and get you an understanding of what it is that we need to do. A sort of refresher course on the anatomy for most of you. And I was telling one of the students earlier that I get a little nervous when I talk in front of some students because they're so right into it, so they know the anatomy better than I do. Because when I studied my textbooks, it was probably about 40 years ago. It's been a while. I just look young because I have a nurse that takes care of me all the time. Anyway, so here's the anatomy that we're talking about, and there's a lot of muscles, but when we break it down to the muscles that we're really treating, there are very few. But you have to know the additional muscles that are there because those are the ones you want to stay away from and avoid. So I'm going to go over each one individually so you have an understanding of that, but this is what we're talking about. And the wrinkle lines on the face essentially are caused by the muscle action, and they're always at right angles to the way the muscle moves. So if you understand that concept, it makes it easy to figure out which muscles you want to inject and which ones you don't. This is a picture of a lady from Southeast Asia, and these lines are tremendous. If I'm trying to rejuvenate her, I've got a lot of things I got to work on. But they're really good evidence of what they do. And these are the lines of the face, are the Langer lines. I don't know if you've heard that terminology. Dr. Langer must have been someone that described that. But basically the Langer lines, as I mentioned, are perpendicular to all the areas where the muscles are working. So when you're looking at the forehead, the frontalis muscle is a vertical muscle essentially that pulls the brows up. So which way are the lines? Perpendicular to that, they are horizontal. The glabellar lines predominantly are those 11s that go up between the eyebrows. So the glabellar muscles that are affecting those lines are the corrugator muscles, which pull the brows down and in, perpendicular to that. Across the root of the nose, you got the bunny scrunch muscles, which are the procerus, and so forth. And we're going to go over each one of those separately. Because what happens is you get these funny expressions that people have. And this is when Hillary found out that she won the debate. She was all excited about that. But the lines of expression, again, are at right angles. And these muscle expression lines can really be dramatic for expression. And that's why when we do these injections, if you do these injections on people that are celebrities or in the limelight or TV personalities, you want to make sure that you do only what you need to do and not anymore because they'll lose that ability to express. So you want to be somewhat careful of that. So let's look at the horizontal lines to start with. Frontalis muscle basically is two parts. There's a left and a right. There are really no central fibers to the frontalis muscle, except there are some decussations across the center. And if you paralyze that area low down, you might actually get some sagging of the medial brow. I mentioned that earlier in one of the other talks. But you can see how these muscles really help hold the brows up. So injecting his brows or his forehead would cause significant problem. You want to stay away from certain areas above the brow. And when I do these injections, I'm always staying away from this outer part in here. The general rule when they talk about injections and you're taking courses are to draw a line halfway across the forehead and stay above that line. I think you have to adjust that line a little bit depending on the individual, but if you stay above that, you're safe. If you go down below that, then those muscles won't be available, and if that's the case, then you're going to have some trouble with brow ptosis, and you don't want that, because then they won't be able to open up their eyes. So that's one of the problems. And most of the lines on the forehead, most of the procerus muscles, 98% of them stay between the temporal fossa, the temporal crest. Most of the forehead muscles are medial to that. If you look at all of you individually, everybody raise up their brows. Yeah, most of them don't go out too far to the side. There's a couple that go a little bit farther. Yours don't. Raise your brows. Okay. Yeah, your hair covers it. Yeah, so they're staying within this range here. So that's good because if they go beyond that and you inject the orbicularis, you're going to get that arching. So you'll know ahead of time which patients are probably going to have that kind of problem. So just look at the anatomy and that'll help you. And we're going to go over that today, so don't be nervous that you're not picking up on things. But generally, if you're staying above that midline where you see the dots on that one picture, that diagram there, you're probably safe. But if you don't, you can have problems. So I just mentioned that most of the frontalis muscle is a left and a right, but they can decussate across the middle. And here's a perfect example. In this interview that Reese Witherspoon had with this person that did the interview, I don't know who he is, maybe the young people know who he is, but you can see how flat her medial brow is between the eyebrows. And this whole flattening area really makes an unnatural look. See, he's got his lines coming right across, which is what his anatomy is. She had that before, but no, she can never deny that she had Botox here because she's got absolutely no movement there. And that's where the problem comes in. Okay? She's got some movement here. Now, if she came to my office for this to be treated, I would probably put a little bit up top here and just say, you're going to have to wait until that wears off. But I could do that to a little relax it so that it won't be quite as obvious. And then we're just putting maybe a single unit in each one of these areas. But she had this whole area injected in here, and that created that flat look, and nobody really wants that, especially a celebrity like that.
Is your point that they injected too low in the center?
I believe, this is not my patient, I wish she was, but she's not. But I believe that they did the corrugator muscles to help her brows relax, and then they injected this lower part of the forehead. And when you look at some of the diagrams, when you study this, some of the diagrams actually show injections of the corrugator muscle and a little bit of that frontalis. You got to be really careful to do that medially, because this is the what you'll end up having. It doesn't look natural. Now, 3 months later, it'll be gone, so the consequences aren't big. But most likely, she said to her plastic surgeon, "I got this interview in 2 weeks. You got to get this thing fixed for me because I want to look youthful on TV," and that's what happened. So nobody really wants that. But the good thing is with the Botox, it's only going to last 3 months. You asked me that question earlier. Do you tell them about the longevity? Yes, you tell them about it because it's not going to last forever. Sometimes that's a good thing, particularly in Reese Witherspoon. So anyway, here's the frontalis muscle. You can see how it does decussate a little bit towards the middle. The anatomy is such that the origin is in the galea, up in the scalp, near the coronal suture line, which is that line that goes across left to right. And it inserts on the skin of the superciliary area above the eyebrows. It doesn't really insert into the bone, bless you. It doesn't really insert in the bone because if it inserts into the bone, there's not going to be any movement there. It really inserts into the skin. And a unique component of this is the depth of that muscle. When you're out lateral, and this is a good thing to write down, when you're lateral on the corrugator muscle, it's more superficial. As you get more medial, it goes a little deeper. So when I do my injections, and we're going to demonstrate that today, I'm more superficial out here and are deeper here. If you're deeper here, then you avoid the frontalis muscle, whatever fibers are. Those come more superficial. So you want to be deep out here, more superficial in here for the corrugator. When you see the anatomy and see how it works, you'll try to avoid those problems. So I don't think the plastic surgeon or dermatologist or aesthetic physician that did it was planning to do it that way, but that's how it worked out. So the other anatomy about blood supply and things like that are not critical, but these are the key points. The key points is the height of the forehead. If you've got somebody with a really low forehead, the last thing you want to do is cause it to come down even lower. You want to look at the areas of maximum movement. This is the most important thing. The strongest muscle is the muscle you're going to target. And if you start with that, then you can tweak it as you become more experienced. So look for that strong muscle where it's the strength is more contraction. You want to inject between those muscles right there, and you'll see that. I'm going to demonstrate that to you. You can look at the age of the patient, the sex of the patient. I don't think those are too critical, but I think they're probably important because if you've got a male patient that's already got heavy brows, you don't want to drop those brows at all. Some women, younger women especially, they've got real stable brows. Okay, so if I'm examining the patient and I'm doing this and it does not move down at all, I can inject her entire forehead till the cows come home, paralyze all those muscles, those brows aren't going to come down. Okay, if I've got somebody that's using these muscles a lot to hold up, like that picture I showed you of Joe Biden, I don't want to inject his forehead because it's going to get even worse. Okay, so keep that in mind. Age is not important unless it affects the way that they look there. And I'll examine some women. If I push down here and it doesn't move down at all, if they want a flat forehead, I can give them a flat forehead. If they've already got some ability to come down, that's a problem. So I'll have them close their eyes, they squint down. If those brows move, and what I'll do is I'll take my, my pen and I'll hold it there, then have them squint down. If that shows you there's a gap there between where it started and where it ends, when they contract, I'll be really careful about injecting her outer brows. So it's a little trick, and we're going to show you that. We'll demonstrate that later. The strength of the muscle is critical too. I had a question earlier about how do you know what dose to put in there? Because when you looked at the table I showed you earlier, there's a range. All right, so in the frown lines, I'll go anywhere from maybe 16 all the way up to 30. How do we know how much to put? Well, we look at the strength of the muscle. Typically, I start out with 20 units of the glabella because that's sort of a good number to start with, because it's sort of an average. And then we'll see how they respond. If they come back 2 weeks later and they're still contracting a little bit, we'll do a little bit more. But when they do come back and you check that contraction, you want to see where the contraction is. Because we're staying a little more medial in general, if they're still contracting a little bit out here, what I'll do is I'll put my fingers here, block it, and then have them contract. If there's no line forming here, then I know it's formed from these outer part of the muscle. We just put a little bleb there, a little bleb there, Botox, and we're done. Question, sir?
I noticed that in your recommendation chart that you have more for men than for women.
Typically because the men have stronger muscles there.
Okay.
Yeah, that's why. So the stronger the muscle, the higher the dose I'll put. And that's on one of the tables I left in the materials I gave you. Okay, so treat conservative. You know, on the forehead, I do 1 or 2 units per spot. You know, that's all you're going to need. I don't think you need much more than that. But I'll do more than 4 spots, and I'll show you. I usually do about 7 spots. And if it's somebody that's first timers, we'll do 7 units, that's it. 7 spots, 7 units. If they're in back and we realize that they need a little bit stronger, then I'll put 14. Again, I'm giving you my experience. I'm sharing you with what we do. That doesn't mean that someone that puts more in there is no less skilled or technique oriented than I am, but that's just the way I do it. Good way to start. Safe area. Good way to start. You want to be in the subdermal plane. You know, you remember the anatomy. We all remember our cadaver dissections. The frontalis muscle is very, very thin. The biceps muscle is very thick. So keep that concept in your mind. Think about the thickness of those muscles. That's why the people in this room are more skilled at doing injections than someone that's a podiatrist, or someone that is a colorectal surgeon, or someone that is a gynecologist. They're used to working in the lower part of the body. Okay, we are skilled at the head and neck area, so you're going to have much more experience because you'll remember the thickness of those muscles. Dr. Tharp.
Frontalis is basically the same fascial plane as the platysma. Platysma is thicker or thinner?
Well, the platysma muscle is a thin muscle, but when we get lax in the platysma, it bunches up and becomes thicker.
Okay.
So, but if we were to look at the cadaver anatomy and they're lying without gravity affecting it, that muscle is very, very thin. Paper thin.
Okay.
Right. So it's sort of the same thing. But when it becomes lax, it bunches up. The frontalis doesn't really bunch up. Corrugators, on the other hand, are thicker muscles. Okay? When that contracts, it's a bulkier muscle. Not thick like the bicep, but much thicker than the frontalis. So we'll do a little different technique in that, and I'm going to show you that when we get to our demonstration. Okay, and stick to the upper forehead. Because this is what can happen. Mephisto, Mephistopheles is the devil. So Dr. Oz has had Botox. I'm pretty confident. He's not my patient, but I'm pretty confident he had it. And I'm not sure why they always do the same thing. But they weaken that frontalis muscle. They get some arching of the brows, and that could be resolved if they wanted to. But I don't know why they don't do it, because every time I see him on TV, he's got that Spock eyebrow. And the treatment of that is pretty simple. Let's just take a little bit of Botox and put some here and some here, not a big amount, and just to relax it a little bit so he doesn't have that. But he's also had that frontalis flattening in here that we showed you on the previous slide. And that frontalis flattening is where his muscles are. And if you have done cadaver dissections, which we all have, you know that anatomy is not the same from one to the other. The muscles cross in different places. So, you know, your colleague might say, hey, come over, take a look at this muscle or whatever, or this nerve. They always are slightly different. So that's why you have to examine the patient during the time of the consultation to decide where you're going to put that. So I'm not, I think he had Botox, maybe he didn't. I don't want to badmouth him, but you have to be cognizant of that. And as I said before, 90%, 98% of the frontalis muscle is between the temporal crest. All right, but if they go beyond that, that's where you're going to get that arching. And if you look at his brows extend beyond that crest. See, they come way out here. So a little bit of Botox here and here in the lower plane would have helped, instead of just doing it here.
He may want that. He may want that.
He may want that. Let's call him up and ask him.
But, well, the question that I have is if you have a patient that says, I want my eyebrows arched, can you always achieve it?
Well, you can't always achieve it, but there are techniques to improve on that, and the women typically want that. And I see patients come back and get a little arching when they come back at the 2-week period, and I say, well, do you like the arch there? She goes, oh yeah, that's great, I love it. Really brings up the outer part of my eye. Okay, you can't guarantee you're going to get it for them, but if you do get it and they like it, fine.
Talk about it ahead of time so that you say you may get it.
Well, I always tell them that there's some consequences. Like I said, the opposing muscles are always affected by the Botox you put into the muscles that are being treated. So those opposing muscles are going to exaggerate it, like in this picture here. There's that Spock eye I showed you earlier. Okay, very simple thing to treat. Okay, if they're both like that and they like it, fine. But you know, like James Cagney had like one brow up on one side than the other, for those of you that are older and know who that actor is. So the muscles aren't always symmetrical. So perhaps on this particular patient, they weren't exactly symmetrical, even though the doctor might have done the same thing, left her with a little bit of a Spock eye there. So you just come back and treat it. If both of them are arched and the patients like it, leave it alone. You know, it's also about what patient wants, not just about what you want. So let's look at the lateral brow. We sort of touched on a little bit. So these marks in that center picture, that center diagram, are exactly what I was saying before. This is what are in the textbooks. This is the marks that they suggest doing for that frown line, that heaviness, and that's what can happen. You can get that flattening there. So just don't do it. Don't do those muscles there unless you're absolutely sure that those are contractions that you don't like. So I'm looking around the room. Some individuals, raise your brows over there. All right, now frown down. See, he's got that muscle in the center. We might want to inject that on him. Good, you can be our demo later. But some people have that where it contracts up here and it contracts down here. Those are perfect candidates for doing this, but not for those that you want to lift up. And then the infrabrow, the very first diagram I show there, we'll do that infrabrow to let that muscle relax, because then the forehead muscle, the frontalis muscle, will be unopposed, and it can just gently bring that up. And that's a really great technique to use. And then we can do all the way along it. I'm very cautious about injecting into the brow in that third diagram there, because then you could get some brow ptosis, and you don't want that, or eyelid ptosis.
So these markings here, not to put the injection.
The traditional markings for the area, and I'm going to show you that in the demonstrations, are right here, right there. And you want to avoid these unless you know the anatomy
Okay.
and you're sure the patient needs it. And I do it. We do it all the time. But it's got to be distinctive anatomy. If you're not sure about it, then just don't do it. And if they come back with a little bit of elevation there, that's a good thing. If they come back, you know, it's not always good to get elevation in the inner part of your brow, because the normal shape of the brow should be a little bit arched on the sides and down in on the inside. You don't want it too far in, because that doesn't look right. That's why you don't want to paralyze this. But coming back a little bit, if they've got a little bit too high in here, you can always come back and put a little bit in there at their 2-week visit. And then you'll know that map, that anatomy, for the next time they come in. But if you inject in the beginning and you're not absolutely sure, you're not going to be happy with that sagging. The patient's going to be disappointed. You're going to be disappointed. Okay. Oh, another question.
I noticed, I don't know how many years ago, it was maybe 5 to 8 years ago, Hillary Clinton, her brow was, her forehead was super smooth, and you know, the rest of her face looked more wrinkly, and that seemed a little odd to me too.
Well,
I noticed it.
there's nothing more important than balancing the face. So like if I have patients that come in that say, I just don't like the lines around my mouth, can you laser those or treat those? But they've got all these other textures and things that are telltale signs of that aging process. Work on the entire face if you can. Okay, so when you're in a practice, if you don't want to do the skin treatments and the lasers and things like that, fine. But say, look, you know, I can relax these muscles for you, make your smile look better. But I want to recommend you go to Dr. Jones down the street, who's a plastic surgeon or dermatologist. Let them work on your skin, because if you want that beautified look, there's more to it than just fixing a wrinkle here or a wrinkle there. And that's good to team up with someone like that. You know, when my brother was finishing dental school, Dr. Degoni, who was at the time president of the American Dental Association, told the class that if you go to a city when you're in practice and you connect with one plastic surgeon, you're going to be successful, because they're going to refer you patients to make the smile better, and you're going to refer them patients to take care of the rest of the look. My brother's fortunate that he was going into practice with 2 plastic surgeons, myself and my dad. So he had it made, and obviously he's done really well. So I have to take some credit for that. But the bottom line is that it's good to partner with people in town that you work with, and they can refer back to you. Could be other dentists too in a different capacity, endodontists or oral surgeons or whatever. The jelly roll we sort of touched on before. You want to hit that mid-pupillary line just below it. You want to just relax that. I mentioned before about using a really small bleb there, very superficial. Or again, remember your anatomy. The orbicularis oculi is a thin muscle, except when it contracts and it gets a little thicker, that's what the jelly roll is. But when you inject it, they're not going to contract so much. You want to put that right under the surface of the skin. You don't want to go deep. If you go deep, you run into risks of getting into the orbit, and that's not a good thing. So you want to what I do is I pull the skin down and just put a little bleb underneath the surface of the skin. Okay, it's really pretty simple, and I'll show you that technique. Hopefully one of the demonstration patients today will have that. We can put that in there for them. The glabellar follow lines, I'm going to go back to that again. We can inject the corrugators as typical, and I always do the procerus with the corrugators. Remember, the procerus is a pull down muscle. The corrugators are pull down and in muscle. Let's relax all those and let that come up a little bit. If the procerus muscle causes the bunny scrunch lower down, and I'll show you a picture of that, then we can inject that lower down. But typically it's 5 injection points that run across the medial part of the brow. Usually it's medial to the mid-pupillary gaze. We're staying medial to that, and that's where the injections go. So it's sort of like these lines here. And again, these ones above there are done if we've got somebody that's got that funny animation there. Okay? If I've got this person on my table, I'm not injecting anywhere above that. We're just injecting the frown lines, either of these persons. Because see how it pulls those brows down. And what's interesting is these muscle actions are what causes the changes over our lifetime. Okay? So it doesn't just cause those vertical lines, it brings those brows down. So in theory, if we relax those when people are young, individuals are young, it's going to maintain that position for a much longer time. And that doesn't just apply to here. It applies to the jowls too. You get these strong muscles coming down to the neck, it's making these jowls form more quickly. If we relax those muscles in the neck, the Nefertiti lift is a great technique to keep that from progressing. So something interesting to look at. So it's that muscle action that creates the lines that changes the anatomy of our face. And just here's a diagrammatic representation of the procerus muscle as it extends up into the forehead. Usually the muscles aren't that prominent as we get that high. And then this is the area that we would treat. This is a picture from the Allergan Corporation demonstrating it. At day 2, some patients start to see the results. Definitely by day 14, it should reach full effect. It takes about 5 to 7 days to start seeing the results. Unlike the fillers, which you see immediately, it takes 5 to 7 days to start seeing the results. So the patients won't see anything for that period of time. So they'll leave your office looking the same way they came in. But then over 5 to 7 days, they start to see the effect. And I see them back at 2 weeks because at that point, it should have reached full effect. If they come in at a week or 10 days, it's too soon because I can't do any additional Botox because I'm still waiting to see the final result. So we give it a little bit more time. And then at 3 months, you can start to see it come back on some will last 4, some will last 5. Patients know when they're ready to get it done again. They'll call you up. If you've got a tight schedule, then I would just book them. 3.5 months later, just book them in. Because if you got a schedule that can't accommodate somebody that calls up and say, oh, I need my Botox right now. It's like one of those Botox emergency calls. You know, it was like a Saturday afternoon, like, oh, Dr. Shatkin, can you see me Monday morning? Yeah, sure. And we get those calls, it's funny. But, you know, it's all fun. But we get those calls and then we'll make arrangements to have them come in. But generally, they schedule them on a regular basis. Once they've started doing it, they know exactly how long it's going to last. And it rarely changes from there. Okay, so let's move down a little bit to the side. Now the crow's feet are really developed from those perpendicular lines from the orbicularis oculi. Now the orbicularis oculi is an interesting muscle because it's circumferential, just like the orbicularis oris. You get orientation of wrinkles that occur in different locations. All right, so the orbicularis oculi out on the side there is a pull down muscle. So if we want to raise the brow a little bit, we might put some injections right up underneath the brow in the orbicularis oculi muscle. But again, it's a very thin muscle, and this is the lines that develop. Okay, so when Obama was asked, can you go see the hurricane victims down in Florida, he goes, well, when I get off the golf course, and he's smiling about it there. I'm just kidding. I'm not trying to get political here.
On that
But-
picture, you'd obviously do the glabella,
Right.
but would you bring that down even further to the? To
Well,
the
if the patient wanted that. And keep in mind this, when somebody's animating extensively, that's not what they normally do every day.
Okay.
Okay, so you don't inject it just because you can elicit that response. Inject it if they are bothered by it. So how will you know that? If they have no wrinkles in that area, in repose, why would you want to inject it? It hasn't been affecting them yet.
Right.
And maybe they only do that when they laugh, and he's a serious guy, so he's never laughing. Okay, but if they see lines start to develop, say they got these lines, the linear radial crow's feet, they're starting to develop, and they're saying, I don't like it where it's accentuated when I animate, then you'll do the injections. So rarely will I do the bunny scrunch area unless I see the deep lines there, and then I can tell them that we can avoid any progression of that. Now, the caveat to that is that I have young people come in and have no lines anywhere on their face because their skin's still youthful and has good collagen and elasticity, and we want to prevent that from happening. And when I say young individuals, I do people in their 20s and 30s that are just starting to see some lines develop there. Okay, so if that's the case, we'll inject them. We'll use a very small dose just to relax it. You don't have to overtreat it, and you'll be doing it for several years before they might otherwise have developed those lines, but you can prevent that. Sort of proactive approach. These are the lines that develop, see? So he's sort of in repose here. He's not like that last picture where he's actively animating. Those lines develop. So if you had injected that individual several years earlier, then they wouldn't be quite as deep. Okay? Does that make sense? Okay, so now one of the other techniques that is important here to remember is that if we're doing the crow's feet, and we want to be careful about getting into the orbit and affecting the intraocular muscles, like in this case the lateral rectus muscle, which would cause some significant issues. The instructors typically tell you to inject away. The needle should point away from the orbit. It's a safer way to do it. I never do that, okay? But that's what the instructors tell you to do. So if you want to be safe and you want to try to be more careful about it, inject away from the orbit, okay? But when you use a tiny little dose with a small needle, the way I'm going to show you today, I've never once had a problem with that. That's a very, very, very rare occurrence, all right? The Mueller's muscle, levator muscle here is much more common. You get into the levator oculi muscle. But it's very rare to happen, but that's why the instructors always suggest injecting away, so I'm telling you to inject away. Another crow's feet area. Okay? So you just want to inject away because that lateral rectus muscle could be affected by it. And they always talk about staying an inch out of the orbit. You can't stay an inch out of the orbit and hit the orbicularis. So around the lateral aspect, you'll try to stay about a centimeter away, half an inch. That's a safe area. So let's go. We're still moving down now, the bunny scrunch area. That's those little bunny rabbit lines there. What we're treating there are the nasalis muscles. Be careful in this area. You don't want to get the levator labii superioris alacanazi, because then that will affect their ability to smile. And unless they have a gummy smile already, you don't want to do that. And I inject the gummy smile, we'll talk about it in a few minutes, but I inject that much lower, even though that alacanazi muscle starts way up in the side of the nose. It's a little more lateral to the nasalis muscle, but that's what's causing those wrinkles in this picture here. And we want to affect those muscles. We put a tiny little dose there, tiny little dose there. I usually use 1 or 2 units there, and that's usually enough. Okay, but you want to make sure that you target exactly where those muscles are. You can't be haphazard with this. With the masseter, it's a big muscle. It's hard to miss it. But some of these fine muscles, you want to be really, really exact. That's the anatomy. Okay, we move down a little further. The depressor anguli oris. I have never seen a picture that demonstrates this better than Bill Clinton. So I hate to pick on the guy, but you know, maybe he's frowning about some political problem that he has to deal with. But these injections can be right down in here and in here. The DAO muscle starts up at the oral commissure and runs all the way down to the mandible, the corner of the mandible. That's where it's attached. So what you want to do is inject it lower down, because the closer you get to the commissure, all those other muscles intervene there. So you want to stay below that. And you can see, if you can look at the close-up of that picture, you've got the depressor labii inferioris, and then medial to that you got the mentalis muscle. And I think most of these pictures are in your...
Blown up one.
Okay, good. Okay, very good. Well, you can also download this because that's where I got it. But yeah, this is a good example. So you want to inject that. So on every patient, just like I said before, I mark the exact distribution of that muscle, because when they relax, I want to see exactly where it is. When they contract, I want to see where it is. So we put little dots exactly where we want to put it. Then we step back. We make sure those dots are where we want it, which is at the lower end of the DAO, depressor anguli oris, and inject it. And that's going to help bring the commissure up a little bit. It's going to relax that muscle, bring it up. You can all feel on your face like Dr. Tharper's doing. Not everybody can exaggerate that muscle like Bill Clinton can. You feel that muscle, bring the bulk of that muscle. Make sure you're not getting this muscle here. Just the angle of the mouth.
Do you ever have them activated before you?
Always activate it, yeah.
Oh, before you inject.
Yeah, we always want to see that muscle. We'll mark it, then we'll activate it again and inject right in that spot.
He's probably thinking about never having sex with that woman.
Yeah, why the heck did I do that? That could be it, I don't know. But maybe he said, why did I waste that time? I could have done more. Okay, so that's it. And you can inject other areas, but make sure, especially if you're doing multiple areas, if you're doing, say you're doing the mentalis muscle, you want to make sure the mentalis stays real medial and the other injections out more lateral, so you avoid that depressor labii inferioris, because then you will get a little bit of distortion of the lip. And it's happened. Doesn't last as long because it's only a small disbursement of it. It won't last the 3 to 4 months. It might last 3 to 4 weeks. You just have to help them carry it through it and get them through the process. I had that happen once, so. And it's usually unilateral because, it doesn't absorb equally. So then you've got the cobblestone chin. So this is the mentalis muscle, okay? Sometimes patients can demonstrate it, sometimes they can't. But if it bothers them, then you inject it. If it doesn't bother them, don't go after it. I don't ever tell a patient, what they should have done. I let them tell me what bothers them. Once they tell me what bothers them, then we can treat it. Okay. So if this is something that bothers them, we can inject that very simple injection. Again, I try to stay low down. We don't want to get up into the lip, the oral, the orbicularis oris, because then you'll get some weakening of the lip itself. But we inject down here. I think 2 to 4 units should be enough for him. That's right. The stronger the muscle, the more you put in.
Would you ever want to, in this case he shows more of his lower lip when he talks, or lower teeth when he talks. Would you want to relax the lower lip?
Well, we can do orbicularis oris muscle for sure. And most of the time we're doing vertical lines in the upper lip. Those are perpendicular to the direction of the orbicularis oris. Smoker's lines, as some people call them, or people that use a straw a lot. So we can inject those for sure. Do it all the time. And it'll just relax it. You don't want to go too deep into the muscle because then they won't be able to animate normally or talk. They'll see some slurring in the speech. So just a very tiny little bit of amount. Even though that's a bulky muscle, we want to lay that on the surface. And we may have a demonstration today. I can show that to you. See the upper lip here? Got those lines there? I was showing them for this reason, but we can inject a little bit there, a little bit there. Those lines will get better. Okay? And then there's the gummy smile. So the pictures in this diagram show the injections a little bit higher than I like to recommend. Usually I do a single injection down just lateral to the nasal, the nares. just lateral to the nares. So my injection for that would be right here and right here, at the lower portion of the levator, ala, canasi muscle. That's where we want to inject it.
One on each side?
One on each side. But you can do two if it's a real strong muscle. But I would start with one. It's conservative, but you'll see how it goes. But if they've got hyperactivity of that muscle, if they've got a gummy smile that's related to hyperactivity, I just want to restate that. Don't do a gummy smile injection there if there's other problems with the reason they have a gummy smile. If they got elongated maxilla where they've got more showing there, then you've got some other reconstructive things. Shorten the gums, shorten the teeth, do that to make a better smile. But I don't think she had any changes to her teeth. I think she just had someone very effectively inject those, and she had a nice result. But there are other muscles nearby, like the zygomaticus, major and minor muscles. You want to avoid that because then their smile will be affected. And it's happened to me, don't like to see it happen, but it doesn't last the full 3 to 4 months. It's usually a couple weeks. Patients say, you know what, when I smile, it looks a little different on this side or that side. Even in the best of hands and following the right techniques, these are not cadavers. We can't open it up and look at it and say, this is where you got to put it. But if you follow general guidelines, you'll be pretty safe. Pretty safe. But I always tell the patients, like the comment before, let them know ahead of time that we're injecting muscles that are not normal muscles to inject to paralyze, and there's some really close by, so it's very possible they might be affected. And I tell them it's not going to last as long if it does, but I'd like to know about it, and they tell me, and then we get them through that first process. Okay. So don't be nervous about it, but also don't be carefree about it either. Okay. If you follow the rules, it's rare to have a problem, but it can happen. Here's another gummy smile patient. I think I showed you these pictures before. So just go a little bit lower than the diagram shows. You can use 2 dots if you want. I'll just stick with 1, so we don't get diffusion. And because you can see right here is the zygomaticus muscle, or the rhosaurus muscle. Here's the zygomaticus major and minor. And then you got the muscles down along the commissure here. Platysmal muscle comes up down, lower down here. So try to stay away from that stuff if you can.
I don't remember the name of the muscle that flares the nose, but if you do it there, you're also going to lose the ability to flare your nose a little, aren't you?
Yeah, sure. The rhosaurus muscle.
Rhosaurus, thank you.
Okay. So anyway, I'm not going to show you this video again, but this is a good depiction of the next technique I want to show you. Well, actually, we'll just let it play for a minute. So it depicts the location for the muscles. Anything that pulls on the neck, we can inject. There are some side effects that are a little bit different nuances, and you can get some dysphagia if those muscles get into the strap muscle of the neck or deeper. So that's why I use the high concentration of the product. This Nefertiti is actually the logo for the American Society of Aesthetic Plastic Surgeons, which I'm a member of, because of that beautiful neckline and jawline. And we can inject those areas. And I used to do just the frontal bands. Now I'm extending to the lateral bands for the patients, because that's where the jowls actually get pulled down. No reason why you can't inject it, but you got to put a higher dose in there. And because the injections are charged to the patient based on the dose you put in, you got significant amount of extra expense for the patient, but you can do it. If they're only bothered by these anterior muscles, then don't do anything else. But if they're starting to see the jowl forming there, and they don't like that pulling down, because usually they don't animate, they don't do this, and people don't walk around doing that. It's more of a temporary thing where they're smiling and like, wow. But they get that expression. But if they're starting to see the jowl pulling down, then you can inject that, just like we inject here, to prevent those lines from developing and to prevent the jowl from developing. So you can see a nicer contour of the jawline. And that's what they can get.
So you would just inject on those 2 muscles protruding?
Right. Well, if they have the anterior, then you inject the 2 muscles that are protruding. I have them animate so I can see the muscles. Then I'll mark it. Then I'll get my Botox. Then I'll have them animate again, and I'll grab it with my fingers, and I just physically put that in there. And I usually hit several areas along the way, usually around 5 points, 6 points, depending on how low it goes. And I'll do maybe 2 to 4 units per spot. I can go up as high as 5, but when we come lateral, it's much more bulkier, the platysma there, so I'll go higher. When they contract that muscle, and I'm hoping we'll have one of the demonstrations today to show, I'm going to put maybe 5 units in each spot. I'll do maybe 15 units in that area, maybe 20. We'll even bring it down a little bit.
If there, you're in danger of stopping the strap muscles from working and having
Right.
swallowing problems?
Some dysphagia, maybe some swallowing, talking, but you don't want to go that deep. Remember, the platysma muscle is very thin. You want to get it in the muscle, but you don't need to go below it. You could probably actually just inject the surface subcutaneously, but I think it's best to get in the muscle there, especially if they've got that band or the heavy band out here, because you'll probably won't get much of an effect. So you want to go into the muscle. And if it's a real thick-skinned individual, you'll have to use a different needle than the one we use for most of our demonstrations.
Is the external carotid a concern at all?
Well, I don't know if you're way down here. Sure, everything's important there. You want to be careful. I hope not. I don't know what would happen if you put Botox in there, but I wouldn't want to find out. Yeah, so all the anatomy is important, but probably more the jugular vessels, internal and external jugular. They're more superficial. Yeah, so you want to be careful of that. So just again, in summary, know your anatomy, customize the treatment based on the strength of the muscle. You want to customize it based on the locations. Make sure you got the dosing and the products, and make sure you're clear on what you want to do. And it's easy enough to just take another moment and recheck the syringe and recheck the dosing, and you'll be fine. Okay, so I've got that one done.